Today's lecture will cover the imaging process. The imaging process involves many phases. Phase 1 is image acquisition. Phase 2 is image processing. Phase 3 is image archiving. Phase 4 is image display, and Phase 5 is image analysis. The CR-DR process involves an image plate exposed on a CR cassette or DR plate. Then the image is processed in a CR reader or DR computer software. The image is archived on a computer screen in digital format. The image is displayed on a computer screen for review, and then finally the image is analyzed for density, contrast, detail, distortion, positioning, etc. Image acquisition includes the following: creation of the X-ray beam involving radiation concepts such as MA, time, KVP, SID, electricity, electromagnetism, the X-ray equipment, the X-ray tube, and X-ray production. Creation of the image includes beam restriction, the patient as a beam emitter, pathology, and the grid. A digital imaging monitor provides a soft copy with the ability to print hard copy on film or a disc. Manipulation of the image and post-processing is available. Archiving is storage of the digital image. Digital images require digital storage space with backup for downtime, power outages, and long-term storage. Digital images can be viewed on a computer screen, any computer, PDA, iPhones, or iPads. With digital imaging, the user can post-process, manipulate, and improve image quality, which involves density, contrast, adding labels, and edge enhancement. The pyramid problem describes minor or major changes that affect one factor, such as density or contrast, may affect several other components of the image. Many factors have individual influence, but also impact other factors as well. To diagnose and treat the image, we review the following. Is the density, brightness acceptable? Is the contrast acceptable? Is the detail acceptable? Was distortion minimized as much as possible? Does the positioning and collimation include all of the appropriate anatomy? And are there any artifacts which obscure the anatomy or pathology? The goal is to achieve an optimal image the first time, every time. Factors that affect this include motion, technical factors, artifacts, and the time taken to perform the exam. You will not always achieve a perfect image. Not all patients can perform routine position. Not all patients are created equally. The X-ray beam is not perfect, and there are factors that you will be unaware of, such as artifacts and pathology. In summary, be aware of the professional imaging standards at your clinical site. Take the time to do the exam right the first time. Allow yourself the ability to make mistakes. Learn from those mistakes, and focus on your strengths to gain confidence and improve upon your weaknesses as you learn. This portion of the lecture will cover density and image receptor exposure. Density, also known as brightness, involves 4 image quality factors. Photographic factors include density and contrast. These factors affect the visibility of detail. Geometric factors include detail and distortion. Definition of density is the overall blackening of a radiographic image. This is a visual result of the image receptor's response to exposure. It is controlled by mass, which is the number of photons reaching the image receptor during a given length of time. This also controls the amount of radiation dose to the patient. The digital term for density is brightness, and brightness can be adjusted by the function window level. Image receptor exposure varies according to the part being imaged, whether it's made of soft tissue, bones, organs, or air. Underexposure creates a grainy or noisy image, also known as quantum mottled, because not enough photons reach the image receptor. Overexposure occurs due to receiving too many photons, and it recorded too much information. It can be adjusted digitally. The primary controller of density is mass. Other influencing factors include KVP, SID, filtration, beam restriction, the anatomical part, if a grid is used, and the image receptor. Mass has a direct proportional relationship to density, so in order to double density, we would double mass. KVP has a direct non-proportional relationship to density. To double density, KVP must be increased 15%. SID has an inverse proportional relationship to density. The mass distance density maintenance formula is used to adjust density as distance is changed. Mass controls the number of photons and the length of exposure. It also affects the quantity of the primary beam. KVP controls the energy, strength, and penetrating power of the primary beam. It controls the average energy of the photons produced at the anode target. It also affects the quantity and quality of the primary beam. Filtration alters the intensity of the primary beam. It reduces the amount of low-energy photons that contribute to patient dose but are non-diagnostic. Beam restriction reduces the total number of photons that reach the image receptor. In turn, it reduces scatter. Technique may need to be adjusted if you're using a large anatomical part, high KVP, a low grid ratio, or not using a grid. The thicker the part, the more scatter is produced. So part thickness affects attenuation, image receptor exposure, and patient dose. Grids absorb scatter, which contribute to density. It requires an increase in mass to compensate for the loss of scatter density. The grid conversion factor formula and factors are used in order to maintain density when changing grid ratios, or going from a grid to no grid. Digital imaging receptors have varying sensitivity to the incoming X-ray photons. In summary, this is a more in-depth look at the image quality factor of density. Review exercise and notes from your mass, KVP, SID, relative speed, and grid lab exercises.